Okay. Hi, I'm Jerry Vockley. I'm the Chief of Genetics at Children's Hospital in Pittsburgh, and I'm going to talk to you today about the treatment of VLCAD deficiency. We'll review current medical management and then talk about a promising new therapy that is before the FDA for approval and hopefully will make a big difference in what we're able to do for the disease. Before I get started, let me just note my conflicts of interest. I have research funding from the NIH and a number of pharmaceutical firms, and I do some consulting on non-fatty acid oxidation disorder issues. When looking at VLCAD deficiency, of course, we're talking about fatty acid oxidation, but it's important to remember that fatty acid oxidation is one of three energy cycles in the mitochondria, and the interaction of all of those cycles is important for maintaining normal energy homeostasis. The cycles are fatty acid oxidation, the TCA cycle, or the Krebs cycle, the tricarboxylic acid cycle, and the respiratory chain. Fatty acid oxidation is the process by which fats released into the bloodstream are imported into the mitochondria through the carnitine cycle, and then through a four-step cycle of enzymatic reactions, you end up with acetyl-CoA, a C2 compound, and a two-carbon shorter fatty acid acyl-CoA that is further oxidized by the pathway. Fatty acid oxidation generates reducing equivalents that go directly into the respiratory chain. The acetyl-CoA feeds into the TCA cycle, which also generates the additional reducing equivalents and thus allow you to make ATP. These pathways both functionally and physically interact. There are some overlapping symptoms that are related to secondary defects induced by the primary defect in the cycles, and in fact, sometimes the secondary defect symptoms can predominate. The hypoglycemia in fatty acid oxidation disorder is not due to a direct deficit here, but a lack of ATP, which leads to an inability to make glucose through gluconeogenesis. So let's take a quick look at what happens when you're required to use fatty acid oxidation. Of course, the pathway is utilized for energy when you're fasting, but also when you're under stress, and that can be physiologic stress, such as high energy exercise state, or it can be disease. When that happens, you're utilizing your glucose, and the glucose, which during times of well, when you're eating postprandially, the glucose is going up and your insulin is dropping, and fatty acids are synthesized. However, when you are decreasing your intake, you need to generate glucose, and you have a mobilization. This is when insulin drops. Sorry, I misspoke on that. And you end up with mobilization of fatty acids from adipose tissue. These fats go through fatty acid oxidation, make acetyl-CoA, and the acetyl-CoA can either go into the TCA cycle or it can make ketone bodies, which is an alternative fuel source. And the peripheral utilization of ketone bodies is another secondary important energy source in fatty acid oxidation defects. When you have impaired fatty acid metabolism, fatty acid oxidation, this process is blocked, and you cannot generate acetyl-CoA or ketone bodies. In the context of long-chain fatty acid oxidation disorders, this grid just shows clinical manifestations that are common, and most of the long-chain fatty acid oxidation disorders have overlapping symptoms. In VLCAD deficiency, what we see are hypoglycemia, typically early in the disease, the first couple of years of life, cardiomyopathy, which can happen anytime, and then recurrent rhabdomyolysis, which, although it can happen in infants, is more seen in older children, especially adolescents and young adults, and it occurs without hypoglycemia typically in those patients. We're quite fortunate now in the United States because, and in many developed nations, in that these diseases are identified by newborn screening. Here you see a characteristic profile, an acyl carnitine profile from a VLCAD patient with C14-1, the most characteristic metabolite in the disease. So once you have made a diagnosis, in the case of newborn screening, the diagnosis is given to us through the newborn screen. The current dietary management is actually fairly limited and predominantly relates to trying to avoid use of fatty acid oxidation. We do generally recommend a heart-healthy diet, which of course is 30 to 35% of total calories from fat. But this is not because the fat in and of itself is toxic. This is not a situation like PKU where you take too much fat and you get a toxic intermediate and it is damaging. It's actually the other way around. The fat that you eat when you're anabolic is being stored, and it is only when you're under stress that you accumulate the whatever toxic products might be there and get into trouble. Nevertheless, we typically need to restrict long-chain fats, not because it's toxic, but because we're trying to supplement patients with MCT oil. MCT oil, or medium-chain triglyceride, is predominantly C8, but depending on the preparations, might have some C10 in it, and maybe even some C12. This bypasses that carnitine cycle, can be imported directly into mitochondria, and doesn't require long-chain fatty acid oxidation to be metabolized. And so giving MCT oil gives these patients a fuel that they can use. We tend to use 2 to 3 grams per kilo in infancy. After the first year or two of life, that may not be tolerated so well, especially as you add back calories from the diet, fat from the diet, and so trying to keep in the 1 to 1.25 grams per kilo is a reasonable goal, and allows you to take as much as 20% of total calories then from long-chain fats. There's good research from Melanie Gillingham's lab that shows that MCT oil is most effective in reducing utilization of long-chain fatty acid oxidation and the accumulation of long-chain acyl carnitine intermediates if given 20 to 30 minutes before a vigorous activity. So break your dose up throughout the day, 3, preferably 4 times a day, and save one of those doses in older kids to be given during activity. Triheptanoin, which we'll be talking about at the end of this session, is an alternative medium-chain fat which generates both C2 and C3 carbon compounds and has an anaplerotic effect on the TCA cycle. The overall dietary management is pretty straightforward. Ensure adequate calories, carbohydrates, and protein. There's data to suggest that a little bit higher protein level here, up to even 15% of total calories, may be beneficial. And if indeed we're restricting long-chain fats from natural fats, we should monitor essential fatty acids to make sure that the patients aren't becoming deficient. If you keep the total fat, the natural fat intake above 10%, that shouldn't happen. But if you're making a formula, or you feel like you need to supplement in an older patient, a combination of safflower and flaxseed oils can be used to balance these nutrients. The dietary requirements for essential fatty acids are not rigorously established, but intake guidelines are shown here, roughly 6 to 7% of calories for linoleic, and linolenic perhaps half to 1% of calories from these two compounds. The dietary ratio of these two compounds we shoot for on the order of 5 to 10 to 1, and you see here a list of linolenic acid-rich foods: green leafy vegetables, legumes, fish, and other seafoods. Other treatment measures are either not necessary when well or controversial, but kick in when patients might be under additional stress. So the first thing is, of course, avoid prolonged fasting, and this is especially important during intercurrent illness. And if necessary, you can admit the patient to the hospital for IV glucose or use an oral glucose solution. As I mentioned, a pre-exercise snack with MCT oil, typically with some other carbohydrates, simply because taking the MCT oil is a little hard by itself. Most patients benefit from a late night snack just prior to bed. This can be carbohydrate and potentially some MCT oil. I am not a proponent of uncooked cornstarch. If you need to use uncooked cornstarch at night to last through the night, what it means is that most likely is that nutritional intake is not adequate, because if your liver stores are normal, this shouldn't be necessary. If for whatever reason you can't get through the night, then a continuous nocturnal gastric drip feeding with a formula that is better balanced, has a better balance of calories, is my preference. You want to have a sick day protocol in place for your patients, and remember that hypoglycemia is a late event in this. Patients are sick, they're starting to rely on fats and can accumulate the intermediates of long chain fatty acid oxidation and be going into rhabdomyolysis before they ever become hypoglycemia, or as adults don't become hypoglycemia. Carnitine supplementation remains controversial. I typically don't use it unless the free carnitine level is in single digits. And I have no data to support this, but it always worries me to have an individual who has a myopathic disease running around with a very, very low level of carnitine, with the concern that it might exacerbate the carnitine, the myopathy, because of an inability to get whatever fats that are still being metabolized into the mitochondria. Now, of course, you're going to watch for hypoglycemia, especially in younger kids, but other manifestations that need to be identified and treated. Rhabdomyolysis. Remember, this can be independent of hypoglycemia. In fact, it's typically independent of hypoglycemia in older patients. High levels of myoglobin in the blood, and therefore in the renal tubular collecting system, it can lead to acute tubular necrosis. And so treating these patients early with high level of fluid and some glucose to try to shut down catabolism is important, both to reverse the catabolic state, but and to avoid the renal disease. D10 half normal saline at 1.5 times maintenance is the usual fluid. And I do that until the CPK is falling. I don't necessarily wait until the CPK levels are in the normal range, because that can take days and days, and by then the patients are already well into an anabolic stage. You can continue the therapy at home with regular food or an oral equivalent of D10 if the patient's not quite yet ready to eat. Some physicians, especially intensivists, like to alkalinize the urine by using sodium bicarb in the IV solution. There's no real data to suggest that that's necessary in fatty acid oxidation disorders, and you really have to get up to extraordinarily high levels of CPK to probably be at risk for ATN. 25, 50,000, sort of usual VLCAD decompensation probably isn't a risk. Once you start getting up into the hundreds of thousands and even a couple of million I've seen, then I think you probably do have some risk. Hyperammonemia is sometimes seen in young kids, babies, and toddlers. This is secondary to the energy deficit and clears rapidly when you turn around the catabolic state, so you don't need to worry about ammonia conjugating agents in this disease. Cardiomyopathy is always a worry. If I have a normal baseline echocardiogram in the recent past and the patient has no signs of cardiac failure on exam, I don't worry about doing an acute echocardiogram every time the patient is sick. However, you do want to monitor them in the house with leads to watch for an arrhythmia and do a formal EKG if you see anything showing up. The sick day home management really varies depending on the age of the patient and how comfortable the parents are. They should always have an emergency letter that explains to an emergency room staff what the disease is and the recommendations. The patients don't inevitably need to go to the emergency room when they're sick. If they have an intercurrent illness or some other involuntary prolonged fasting, they've had a bug, they're getting over it, but they're still not eating well, or the most worrisome symptom, they're vomiting, because then you can't use oral treatment, then you might need to get them to the emergency room. But don't rely on a glucometer, as I mentioned, to make that choice. At home, you can easily give oral glucose solutions. If the patient's awake and able to drink and not vomiting, you can do that via PO fluids, or if they have a G-tube, which really makes management of these patients easier when they're young. You can just start a D10 equivalent enteral solution. Well, you can make that out of a soul carb plus into something with some electrolytes like some Pedialyte. If you can't keep that up, then admitting for IV glucose is appropriate. Now, in spite of all of that therapy, these patients still end up with intermittent episodes of decompensation, and the question of why that occurs when we're giving them MCT oil, which theoretically should get around the metabolic block, has to do with a theory that centers on the TCA cycle, here shown in greater glory. And what you can see from this is that acetyl-CoA, which enters the cycle at the highest point, flux through citrate synthase, a little bit through malate synthase, is a key starting point for the cycle. But the cycle also needs succinyl-CoA, or odd chain carbons, which come in through propionyl-CoA. Under stress, when energy is not being delivered directly via the fatty acid oxidation cycle to the respiratory chain, what happens is that acetyl-CoA from C8, MCT oil, comes in here, and the cycle functions at a higher level because you're using it for at a higher capacity for a higher rate for energy generation, and it runs and it runs and it runs until it runs out of 3 carbon units. And the goal of anaplerotic therapy is to provide additional 3 carbon units that can help. Now you can give succinate, that's not bioavailable orally, and so we've developed a protocol using a triheptanone. Originally, the triheptanone was originally developed by Charlie Rowe, and more recently I've been working with a company, Ultragenics, in a phase 2 trial to make that to test its effectiveness, and also with Melanie Gillingham on a study that was funded by the FDA Orphan Products Act to look at energy metabolism in patients treated with triheptanone. So our FDA trial was a double-blind comparison of C7 versus C8. We brought them into the hospital. We did a very complicated series of energy balance studies, functional studies, and then started them on either C7 or C8, again blinded, sent them home for 4 months, and then brought them back and did the same thing. What we showed is that the cardiac effect of triheptanone was the major benefit in this study. It improved the left ventricular ejection fraction. These patients had normal cardiac function to start with, but it also they had a lower heart rate for the same amount of work performed. This is on top of, compared to MCT oil, this is on top of a similar improvement in MCT oil compared to a carbohydrate diet that Dr. Gillingham had previously shown and published. So given the cardiomyopathy that these patients are at risk, this looks like it is a good effect to have in the study. We didn't see, oops, we have some glitches from my Mac to PC conversion here. We did not see an effect on clinical outcome, episodes of rhabdomyolysis, things like that, because we were only following a relatively small number of patients for a short period of time. To better address that, we did both some retrospective studies on my experience with use of triheptanone, but then in collaboration with Ultragenics, their name for this compound is UX007. We developed a very rigorous protocol to look at long-term treatment of fatty acid oxidation defect. You can see the details of the trial here, but the bottom line is that we were looking at the effect on major clinical events, hypoglycemia, cardiomyopathy, or rhabdomyolysis of triheptanone in the time frame after starting treatment compared to the 12 months before starting treatment. This is just the characteristics of our patient populations and their clinical manifestations. And the take-home point is here. The overall major clinical events in patients treated with triheptanone at 78 weeks, and this is not just rhabdomyolysis now, this is everything. There was an almost 50% drop at a statistically significant level in overall events, rhabdo, hypoglycemia, and cardiac. The individual levels didn't reach statistical significance because of the relatively small patient population, but overall it was statistically significant. Patients also said they felt better. They on a short form physical and mental component, they said they had at the 24-week level here on the adult side, more importantly, a decrease in physical complaints. And there were no real safety concerns. We had adverse events that paralleled what we see in patients with MCT oil at no difference than they were seen in the 12-month lead-in period to the study. So we think this is going to be an effective adjunct in our treatment of VLCAD. It is before the FDA, and it will now and will be submitting the formal new drug application after the first of the year, and we'll hopefully have that in our armamentarium in the coming year. So with that, I say thank you for your attention, and I hope you have found this useful as our lovely medical center, and that's we'll call the webinar to an end. Goodbye.